Since we are going to be going really fast today, I'm just going to jump right into a case. We've all seen this patient before. 25-year-old guy comes in confused, agitated, BP's elevated, heart rate's elevated, but wait, this is something we don't necessarily see all the time. His rectal temp, true case here, was 113. 4 hours later, these are his lab results, okay? He made a trope, he's got a CK, creatinine's up, and AST's in the thousands range. So just take a moment and think, what do you think is going to happen to this patient? What's their clinical outcome? What's their hospital course? Well, the next day, actually, I went to see this patient, and he was extubated. He was actually doing fine. He was walking around, alert, oriented. He actually was holding a newspaper, walking around the ICU. I thought that was very odd, to say the least. But he was doing quite well. So we're going to talk about how this patient did so well and how you can do that. So I like to call this talk Serotonin Syndrome and Other Things That Make You Hot. We're going to talk about these 4 different types of tox hyperthermia: serotonin syndrome, neuroleptic malignant syndrome. We're going to get into malignant hyperthermia briefly, and then general sympathomimetic overdose. The objectives today: the first thing I want you to make sure that you leave with is how to identify one of these 4 patients. The next thing is we're going to just really briefly touch on some of the distinguishing features, because all of these ultimately can look very similar. And lastly, we're going to discuss the critical actions in managing these hyperthermic patients. So we'll start with serotonin syndrome, and not to be confused with the band Serotonin and their album, The Syndrome. I did not make this up. You can Google it. Their music rocks, okay? And they actually, you can't see this, but they put the serotonin molecule on their album cover. So what do we know about serotonin? Does lots of great things. It improves mood, it affects temperature, it regulates nausea. We modulate it when somebody's coming in the emergency department vomiting. What we know is that selective serotonin reuptake inhibitors are one of the most commonly prescribed medications out there. Since the advent of Prozac in 1987, it's usually number 1, 2, or 3 as far as commonly prescribed medications. We know they're used for depression, anxiety, many FDA-approved usages and non-FDA-approved usages. And I just recently learned that it's also used for dog separation anxiety. So if your dog's always barking when you leave, you might throw them a little Prozac before you go to work. Serotonin syndrome, if you look it up, this is a classic triad. But just like in medicine with other triads and classic syndromes, this really doesn't help. So you have altered mental status, autonomic instability, and neuromuscular abnormalities. I throw this up there first because any one of the tox hyperthermia causes really can present like this. So we really need to get into a better definition or a better way of identifying serotonin syndrome. It's easier to think of it as an excess of serotonin. So it's an excess stimulation in the central and peripheral nervous system. Now, as a toxicologist, I would love to go over every step of the synthesis and stimulation of serotonin at the presynaptic and postsynaptic receptor, but the main thing I want you to take from this slide is there are many ways to modulate serotonin and increase that pathway's stimulation. So you can increase the amount of precursors that you give the patient, you can enhance the release, and obviously when we're talking about SSRIs, you can block the reuptake. So this is easy, right? So if you overdose on an SSRI, you're going to have serotonin syndrome. Wrong, actually, okay? Many of you I recognize, you've rotated at the Poison Center with us. You've done many callbacks on pure SSRI overdoses, and you realize this doesn't happen very often. And actually, in one study, only about 16% of patients who had a pure SSRI overdose had signs of serotonergic excess or serotonin syndrome. So when does it occur? Well, we know it can occur with a single dose, which is rare but has happened. We know it happens at therapeutic dosing, and we know it can happen if you've been told to increase your dose or double your dose. But the most common thing is a combination of one or more pro-serotonergic agents. So it can be quite difficult to identify the exact cause. Sometimes patients don't know that they took another medication that had a pro-serotonergic effect. And I'll give you a few examples. The main thing here, and the clock is ticking on my lecture and on you treating this patient, okay? This presentation happens minutes to hours after the exposure. So they're on an SSRI, they take something else, they are going to present within a few hours. Some pro-serotonergic meds, obviously the SSRIs. We don't see the MAOIs anymore, but they had one of the strongest pro-serotonergic effects. Venlafaxine, valproic acid, lithium, lots of different medications. Meperidine or Demerol is not really around anymore due to multiple adverse effects. Some people are very sad about that, but serotonergic effects were remarkable with this drug, okay? Lynasalid, just a kind of quick tidbit here, but it's a drug we obviously use for MRSA infections, classic serotonergic syndrome causing drug. If you look in the literature, there are about 20 case reports of this. Dextromethorphan is probably the one that I think we see the most. Someone's on an SSRI, they have a cold, they don't realize they're using some dextromethorphan that's in NyQuil or some kind of cough syrup preparation, or they're abusing it, which obviously you know happens. There are lots of street drugs and illicit substances out there. Some of the new ones like K2, Spice, the synthetic cannabinoids, and the bath salts may have some serotonergic effects, which is why we have seen some of the agitation or hyperthermia in some of these patients. So serotonin syndrome or serotonin excess presents with a broad range of clinical presentations. If you ask anybody who started an SSRI, they might tell you in the beginning they feel a little tremulous, they feel a little sweaty, and that usually goes away in a couple days after they get used to the medication. Now there's a few different sets of criteria out there. Some of them are outdated. I use the HATS criteria, which is the Hunter Area Tox Service. It's a group out in Australia, and essentially what they did is they put this criteria together, and you need to memorize it, right? So any exposure to a serotonergic med, and then one of these 5. So tremor and hyperflexia, spontaneous clonus, and you can see the others here. You can't memorize this. I can't even memorize it, okay? But I want to make things simpler for you. So I thought, I'm a genius, right? Serotonin sounds like tone increase, right? So I want you to think of 2 things here. You're going to think of hyperreflexia and clonus. And I have to make the admission that the people who actually discovered the serotonin molecule realized that it increased the reflexes, it increased the blood pressure, it increased the tone. So that's why they named it serotonin. It was found in the serum. So I'm not a genius. So you go back to the Hunter Area Tox Service criteria, which was combined with a paper by Ed Boyer. And if you look for hyperreflexia, you see that it's really only in one of these 5 sets of criteria. And if you look for clonus, you actually see it's in 4. So if you don't see hyperreflexia and clonus, it's very unlikely that you're dealing with serotonergic excess. But you got to make sure that you examine the eyes. And if you've never seen ocular clonus before, it's insane. The eyes basically look like they're bouncing around. When we had MAOI crisis and overdoses, we used to call this a ping-pong gaze. So the eyes are just bouncing around. The other area that you want to look for clonus is obviously in the extremities, and you want to assess for hyperreflexia. Interesting enough, and this is anecdotal, but it's been repeated multiple times in case reports, that the hyperreflexia seems to be greater in the lower extremities than the upper extremities. So I would just take a moment to mention, since we're going kind of fast, many of these things are summarized beautifully in Ed Boyer's New England Journal of Medicine paper in 2005, and this is just a picture describing what someone with serotonin syndrome might look like. So moving on to neuroleptic malignant syndrome, and I'm gonna read something real quick here. So when haloperidol was introduced in the 50s, they started noticing something happening. They noticed patients often had difficulties in chewing and swallowing, excessive salivation, total insomnia, rapid wasting, and obliged us to interrupt treatment. So right off the bat, they were seeing neuroleptic malignant syndrome. This is the best description that we have, and to this day, this is exactly what we see time and time again. So NMS, once again, is kind of a weird diagnosis. It's a diagnosis of exclusion, as many of these others are. And if you look at the DSM-4 criteria, you'll see that it's basically severe muscle rigidity, which often you hear is called lead pipe rigidity, an elevated temperature, and then 2 or more of the following. And so it's just kind of a potpourri of different signs, symptoms. The only lab that I could even mention in any of this talk is an elevated CK, which is often seen in NMS. Once again, broad spectrum of presentation. The etiology here is different. It's a etiology from the dopamine blockade rather than dopamine excess or rather than an excess stimulation that we see in serotonin syndrome. So essentially, what you get patients who've gotten too much antipsychotics or other dopamine blocking drugs, or patients who are withdrawing or haven't been given their dopaminergic medication. The best is to think of NMS looks a lot like Parkinson's, right? Which is obviously the etiology is related to dopamine blockade. Once again, a very complicated pathway which we really don't understand, but we'll get to the commonality in all of this. So NMS timing here is slow, and it's often an insidious onset. The classic thing that I hear is my cousin, my husband, my wife, so-and-so is not taking their psych meds. They're kind of not wanting to eat, so we're going to give them more medications, right? So that's just complicating the picture of NMS further. Malignant hyperthermia, real quick. It's a rare inherited disorder, okay? It occurs about 1 in every 60,000 OR cases. And this here is a very cool picture. So you guys probably remember from med school that MH is associated with an abnormality in the ryanodine receptor. What I want you to think about is essentially calcium gets released in the muscle cell and cannot be brought back in, so you get this tetanic contraction. We do DNA testing now, but not too long ago they would take a muscle biopsy, put it in a petri dish with the 2 ends on a paper clip, add some medications, and actually watch the muscle contract and bend the paper clip if the patient has, concerning, I guess, receptor physiology for malignant hyperthermia. So how does it present? It usually presents in the OR with a rigid chest, rising end-tidal CO2, and obviously hyperthermia. It's classically seen with the combination of an inhalational agent plus succinylcholine. So why should an EM physician be worried about this? Well, here's the one take-home point. I think everybody here knows that masseter spasm can be an adverse event that's associated with succinylcholine. What I want you to do, if you see that masseter spasm, right, that is a strong association that patient will develop malignant hyperthermia if they get exposed to an inhalational agent. So the patient who's going to go to the OR that you just intubated that maybe had a little masseter spasm, you need to tell anesthesia about this. They can give them other agents for anesthesia other than the classic inhalationals. Last thing, sympathomimetic overdose. Not going to spend really much time on that. You guys know what this is, okay? Lots of different stimulant drugs that can cause this. So just imagine for a moment before this talk, what would you think the most common cause of death from cocaine would be? I used to think it was cardiac, right? MI, dissection, something like that. But you got to go back in time to the 90s, and you look at the ME report that published actually out of the New York City Medical Examiner here. They looked at opioid deaths throughout the year, okay? And they were pretty much the same average amount of deaths from opioid every day. And then you look at cocaine deaths, and you see something very interesting happen here. And on the bottom, you have maximum daily temperature. And when you hit 88 degrees, okay, essentially, the cocaine deaths spiked dramatically and statistically significant, all right? Now, this really relates to the fact that most cocaine overdose deaths are hyperthermic deaths. So how do you remember the 88 degrees if you're worried about it? Well, there's another thing that happens very quickly when you go to 88 degrees or 88 miles per hour, right? So this is very dramatic. So much of these deaths were occurring obviously during the summer months, and patients were essentially overheated. Treatment, last couple minutes here. It's very easy. When you see a patient like this, think this. So what are you guys going to yell to this patient? Stop, drop, and roll, right? I found out that does not work everywhere, okay? So I have come up with my own mantra, and that's stop, calm, and cool, okay? You're gonna stop or refrain from adding any serotonergic, antidopaminergic, or any other medications that may complicate this picture. You're gonna calm this patient aggressively, and that means aggressive benzodiazepine use, and it also means intubation and paralysis if needed. But one of the most important things that I do not see done very well is you need to cool these patients rapidly, okay? You need to get them under essentially 102, 103 very quickly. Now, we don't have any specific evidence for this in tox hyperthermia, but we've got tons of evidence from hyperthermia in the past. And we know the longer you spend hyperthermic, the worse your outcome's gonna be. Heat is essentially bad. It's going to denature proteins, and it's associated with all of these complications that you know about from hyperthermic or heat stroke, okay? DVTs, rhabdo, etc., okay? But I want you to think of one of my favorite foods here, okay? When the patient is burning up, their liver, for example, is searing, all right? So that LFT rise is essentially their liver frying. So the pitfalls I see in cooling are essentially this. You do not want to use fans and cooling blankets, misting, and fans, all right? That just does not work unless you have one of these and one of these, okay? The study that actually this worked took patients to the top of the roof, doused them with a hose, and they were sitting underneath a helicopter blade, okay? We do not have that. We don't have that access to a helicopter blade at this time in our emergency department. Maybe we will in the future. Ice water immersion or ice bath immersion is the best, okay? But that's not very practical. So what is practical? What we do here at Bellevue is we have this bed that has 4 walls. It's called the Cholera Bed or the delousing bed because it's got a hole in the bottom that can drain. I know, it's kind of nasty actually. You lay ice down, okay, and then you get a bunch of medical students also to fill bags of ice, right? And you just cover the patient completely, okay? And that is going to essentially cure this patient of their hyperthermia quickly, all right? Running out of time here, antidotes essentially don't work, okay? Everybody wants to know the antidotes because it's a tox talk. Cyproheptadine for serotonin syndrome, bromocriptine for NMS don't really work very well. You need to cool this patient. If you're dealing with malignant hyperthermia, dantrolene is very important, okay? Going back to this patient, what did they do that saved his life? Easy. They aggressively sedated him, intubated him, covered him in ice, and his temperature dropped to 102 in about 20 minutes, okay? So in summary here, any one of these hyperthermic syndromes, essentially it's related to the excess muscle rigidity and the excess heat that the body is producing, which leads to the hyperthermia, which leads to death. So if we stop the muscle rigidity using our stop, calm, and cool method, we are going to prevent death, okay? We don't have time for examples, but just wrapping up, obviously remember those points that we talked about, and please call your local poison center. Thank you very much.